All right, today we are diving deep into a really common and frankly debilitating problem, delayed gastric emptying, also known as gastroparesis. We're going to trace the entire chain of command, from the brain all the way down to the individual cells to figure out what happens when the stomach's super intricate machinery just stops. Let's get into it. So, what does that even mean when the stomach's motor just fails? This is not just a simple case of indigestion. We're talking about a fundamental breakdown in the body's ability to get nutrients, a process that's, well, essential for life itself. And for the people dealing with this, that breakdown shows up as this miserable collection of symptoms. Constant nausea, vomiting, that feeling of being full after just a few bites, what we call early satiety, and of course, that uncomfortable bloating. So our whole goal today is to connect these very real symptoms back to their precise physiological roots. Okay, here's our game plan. We'll start with the gut's control system, kind of the top-down management, and see how a healthy stomach is supposed to work. Then we'll get into the two major ways it can fail. First, its ability to even hold food, and second, its power to push it forward. After that, we're going microscopic to uncover the cellular sabotage that's really at the heart of the problem. And then, of course, we'll wrap it all up with the key takeaways. So first up, the gut's control system. Look, to really get what goes wrong in gastroparesis, we first have to appreciate the unbelievably sophisticated system that's in charge of normal gut movement. Just think of it like a three-level hierarchy, right? At the very top, you've got the autonomic nervous system. That's the external command coming from the brain and spinal cord. Now that system talks to the gut's very own brain, the enteric nervous system. And then finally, that enteric system gives the marching orders to the smooth muscle cells. Those are the troops on the ground actually making the stomach contract. Now, this chart, this really shows the beautiful push and pull going on. The parasympathetic system, that's your rest and digest signal coming down the vagus nerve, it's the one orchestrating the whole meal response. So you can see here, it tells the fundus, the top part of the stomach, hey, relax, make some room. It tells the body in the antrum, the main grinding area, time to contract, and it tells the pylorus, that exit gate, open up. Meanwhile, the sympathetic system, your fight or flight response, it's the brake. It does the exact opposite, just shutting the whole operation down. Okay, so let's move on and see how this all comes together in a healthy stomach. And it really operates in two totally distinct modes. Yeah, so when you're fasting, the stomach is basically a housekeeper. It uses these really powerful sweeping contractions, we call them migrating motor complexes, to clear out any leftover junk. But after you eat, in that postprandial state, it completely transforms into a reservoir and grinder. The top part chills out to hold the food, and the bottom part gets down to the serious business of mechanical digestion. And that grinding process, it has a specific name you need to know: trituration. This is the absolute critical job of the antrum. It's producing these high-powered contractions that just pulverize solid food, breaking everything down into tiny particles, like 1 to 2 millimeters in size. Only then, when they're that small, can they get through that pyloric sphincter and into the small intestine. Okay, so what happens when this elegant system just breaks down? Let's get into our third section and look at the first major failure point: accommodation. This is when the stomach's ability to act as a reservoir is totally compromised. And a classic example of this is functional dyspepsia. You'll see these patients, they have all the symptoms, the nausea, pain, bloating, but when you scope them, everything looks totally normal. The problem isn't the structure, it's the function. And in about a quarter of these folks, the real issue is that impaired gastric accommodation. The stomach is just less compliant. It can't relax and stretch the way it's supposed to. So that directly leads to that feeling of getting full way too early and the pain, because even a little bit of food causes a big spike in pressure. And there's even some evidence that this can kick off after an infection or as part of an inflammatory process. Another huge condition where we see these problems is, of course, diabetes. But, and this is really important to get, the link between diabetes and stomach symptoms isn't as simple as you might think. The reason why they're having symptoms can be surprisingly different from patient to patient. And this slide right here illustrates a super crucial clinical point. If you have a patient with diabetes who has upper GI symptoms, you can't just automatically assume it's classic slow emptying gastroparesis. Look at this study. Over 100 symptomatic patients and only 19% actually had delayed emptying. What was way more common? Well, either reduced accommodation with normal emptying or, believe it or not, rapid emptying. This completely changes how you'd even begin to approach their problem. All right, now let's shift gears to the other major way things can go wrong: problems with propulsion. So here, the issue isn't the reservoir. It's that the grinding mill in the antrum and the gatekeeper at the pylorus are failing. The antrum can fail in a bunch of different ways. You can have mechanical problems like hypomotility, where the contractions just aren't frequent enough, or reduced amplitude, where they're just too weak. Then there are electrical problems, where the rhythm goes totally haywire. That's called dysrhythmia. And finally, you can have a straight-up exit problem, pylorospasm, where the door to the small intestine is basically slammed shut. And for our patients with diabetes, this quote highlights a really powerful real-time effect. This isn't just about long-term nerve damage from years of poor control. Acute hyperglycemia, high blood sugar right now, can bring gastric motility to a screeching halt. This study showed that at a glucose of 250, contractions were pretty much gone. It's a dynamic process that we can actually influence with good glycemic control. Okay, so for our fifth section, we're going even deeper to find the root cause. We've seen all the functional problems, but what's the actual cellular damage that's driving all this? It's a really critical question, right? Is it the nerves? Is it the muscle itself? Or is it something else entirely? Well, the research is pointing towards a very specific and incredibly important type of cell. And here they are, the interstitial cells of Cajal, or ICCs. You can think of these as the master pacemakers of the gut. They're the ones generating that slow-wave electrical rhythm that the smooth muscle just follows along with. And in both diabetic and idiopathic gastroparesis, a key finding is the loss of these absolutely vital cells. No pacemaker, no coordinated rhythm. It's that simple.
So why are these crucial pacemaker cells just disappearing? A leading theory points to an imbalance in the immune system, specifically with two kinds of macrophages. You've got the bad guys, the pro-inflammatory M1 macrophages that pump out all these damaging factors, and then you've got the good guys, the protective anti-inflammatory M2 macrophages. The thinking is that in gastroparesis, that balance gets thrown off. You get way more of the destructive M1s and fewer of the protective M2s, and that leads directly to the injury and loss of that whole ICC network.
All right, let's put this all together. In our final section, we're going to build a unified framework to really understand the pathogenesis of delayed gastric emptying. So here are the core mechanisms, the big picture. 1, you can have a failure of the fundus to accommodate the meal. 2, you can have a failure of the antrum to grind and propel the food. 3, you can have a failure of the pylorus to open properly. And underlying a lot of this, especially in the more severe cases, is the loss of those critical ICC pacemaker cells, which is likely driven by a whole process of inflammation and oxidative stress. And that brings us to our final thought. If the root cause is really this complex dance of inflammation and cellular loss, it kind of suggests our current treatments might be missing the mark, right? I mean, instead of just trying to force the stomach to move, could future therapies actually focus on repairing the cells and modulating that immune response? That's the billion-dollar question that's driving the next wave of research in this really challenging field.